the content, I will talk about the introduction, the case description, and also the discussion. So the term malignant is used by Hacker et al. It is a complete infarction of MCA territory, accompanied by space-occupying mass effect that cause rapid neurological deterioration. It develops during the first 5 days after presentation. So less than 10% of ischemic stroke classified as malignant. More than 50% MCA involvement cause high risk of malignant evolution. So the prevalence of malignant MCA, especially caused from an open wound, is not exactly known. With the conservative medical management only, there is nearly 80% mortality rate. So this 53-year-old male came to our emergency unit with a chief complaint of lacerated wound over the left wrist. So 15 minutes prior, he was accidentally cut himself while chopping a coconut shell. He arrived at the emergency department, and 30 minutes later, he developed weakness and numbness on the left side of the body. There are also associated symptoms such as he vomits twice, he developed severe headache, but he could understand all spoken words and speak fluently. There are no history such as decrease of consciousness, seizures, and visual disturbance. So on the physical examinations, we found the vital signs. The blood pressure is 150 and 80, and the others is within the normal limit. The GCS is 15, and the pupillary size of blood pupils is 3 mm, and both pupils have a light reflex. So on the neurological exam, we found a complete paralysis of both upper and lower left side of the extremities. There are decreased sensibility to pain, temperature, light touch, pressure, and also proprioceptive. There is also a central cranial nerve 7 palsy on the left side. So the examination of the wrist, we found a lacerated one that was approximately 3 cm in length, 0.8 cm in depth. There are also several clots and debris around the wound, minimal bleeding, and there are no deformity or cavitation, and the CRT is less than 2 seconds. On the supportive examination, on the CT scan, we found a large hypodenation with associated edema in the location that's supplied by the right MCA. We also found a subpulsing herniation, a compressed right lateral ventricle, and also a midline shift more than 5 mm to the contralateral side of the edema. These findings suggest a high ICP. So in the management strategies, the open one was managed surgically. We found a ruptured cephalic vein and radial artery with several clot and debris around it. The ruptured blood vessels was ligated. No facilities to support the surgical procedure to repair or reanastomosis the ruptured vessels. The embolic stroke and edema cause significant intracranial hypertension. The decompression procedure is the standard treatment to treat this patient, but no facilities to support the surgical decompression, and the patient refused to refer to a higher medical facilities that can support this procedure. So we only treat the patients conservatively. So the conservative management in these patients, this is a standard treatment especially in patients with high ICP. So we close monitoring the ICU, close monitoring the patient in the ICU. We use oxygen nasal cannula, elevate the head of bed 30 degrees. We use mannitol 20%, paracetamol infusion, ranitidine, citicoline, and mecobalamin. So the patient was treated conservatively for a total 12 days of treatment, and we found no improvement of the current deficits. So the patients remain hemi-anesthesia and hemiplegia on the left side of the extremities. The patient was followed for at least 2 months after the injury, and we found no improvement nor worsening of current deficits. He only able to perform daily activities with a total support and unable to work as a farmer, which is his livelihood to support his family. So the modified ranking scale in this patient is 4. There are no follow-up CT scan due to some financial problems in this patient. So the discussion: ischemia of the 2/3 of the MCA territory could predict the development of malignant evolution. There are also high risk for deterioration and death that correlates with more extensive amount of necrotic brain tissue involved. Early neurological decline should alert clinician to this syndrome, with development of symptoms such as headache and vomiting, and also supported by the radiological evidence. The malignant cerebral infarction can cause severe post-ischemic edema that's showed by high ICP, cerebral herniation, and progressive brainstem dysfunction. So non-thrombotic embolic stroke, same in our case. This is currently anecdotal and based on small case series. It rarely causes a malignant transformation. The source of this embolic stroke came from the amniotic fluid, tumor, fat and cholesterol, and also the intravascular embolic debris or foreign objects. So it can cause from injured vessels, in traumatic or iatrogenic. In iatrogenic, it can cause from some vascular procedures or endovascular therapy. Non prevalence of embolic stroke cause from an open wound, especially the traumatic cause. And it can cause from either vein or arterial origins, but in our case, it's suspected from a ruptured cephalic vein. So the treatment is especially to remove the embolic debris. We can do thrombolysis or embolectomy, but there are no such facilities in our institution. So the treatment options, the first line is according to the some literature that we found, we have to use surgical decompression as the procedure, but no such facilities to support this procedure. So we only use the general measures and pharmacological agents, and the only management that we can use in our institution. So the general measures, same that perform in our institution. So 30-degree head of bed elevation, IV fluids to maintain hypovolemia, maintain the oxygen saturation, medication to prevent stress ulcer, and also close monitoring in the ICU. So the pharmacological agents that we use, the first line is osmotherapy. This is the first line medical treatment for malignant cerebral infarction, but there are few clinical trials study their impact on clinical outcome. It cannot be used prophylactically because it increases the infarct volume. It usually used as adjunctive therapy to decompressive craniotomy. So the therapy consists of mannitol and hypertonic saline. So the other general measures and pharmacological agents, okay, there are no benefit to use corticosteroid in the malignant cerebral infarction. How about barbiturates? Barbiturates is not recommended because no randomized studies in cerebral infarction. Hyperventilation may worsen the infarction and only act as temporary measure while waiting for a more definitive treatment such as decompressive craniotomy. Temperature control by maintaining the normothermia. Induced hypothermia remains investigational in malignant cerebral infarction. So, conclude all this finding. Clinical outcome is frequently catastrophic when only conventional medical treatment is applied, with mortality rate nearly 80%. So how about surgical decompression? There are no guidelines in the context of malignant cerebral infarction, but in the few years, randomized data have been published addressing the role of yearly decompressive craniotomy. Surgical decompression may improve the survival but increase the proportion of patients with significant disability. But it can decrease the mortality ranging between 15% and 40%. So based on the European Multicenter RCT, Destiny, Decimo, and Hamlet, the results of a full analysis of the 3 RCT that significant reduction in one-year mortality in the surgical decompression group. So there is 29% mortality in patients undergoing DC compared to 78% in the control group. In patients less than 60 years, DC within 48 hours significantly reduced the mortality compared with the best medical treatment. With modified Rankin scale less than 4 in 1 year is achieved 25% of patients in the DC group compared to only 24% in the non-operative group. Therefore, we conclude that decompressive craniotomy significantly reduced the mortality in malignant cerebral infarction. So how about the ESO, European Stroke Organization guidelines? It also recommended decompressive craniotomy within 48 hours after symptoms, onset in patients up to 60 years of age with evolving MCI. So we conclude both European Multicenter RCT and the ESO guidelines. He said that surgical decompression within 48 hours in patients up to 60 years of age significantly reduce the mortality and improve the functional outcome. So the conclusions, malignant MCA territory infarction is rarely caused by an open wound injury. Any type of open wound should be managed properly to prevent entering of debris into the circulatory system. Although high mortality, nearly 80% with conservative management, miraculously the patient survived but with significant disability. So I took quotes from Wilder Penfield. This is he is an American Canadian neurosurgeon who developed several methods in brain surgery. This is my favorite quotes. The brain is the organ of destiny. It holds within its harming mechanisms secrets that will determine the future of the human race. So this is the references that we use. Thank you for your attention. Kindly visit our Instagram and Facebook for further information. Please kindly stay fit and stay healthy in this pandemic. And once again, thank you for your attention.
Thank you very much, Dr. Christopher Lauren, for the very nice presentations. Maybe there's one question from Dr. Arianito Widinugroho. What is the reasons that the decompressive craniotomy is not being able to perform in this case? Because it usually can be done with basic neurosurgical instruments and with good outcome. Maybe you can explain to the audience.
Yes, thank you, Dr. Arianito. So thank you for the question. So why we are not able to perform the decompressive craniotomy in our institutions is because we lack of resources to do the procedures such as Jiggly saw And then we don't have instruments such as the cranial perforator to make the blue hole. So it prevents us to do such procedure in our institution. So we only manage with only conservative medical management only.
Okay, thank you very much, Dr. Christopher Lawrence. Maybe we can move to the next speaker for the sessions, Dr. Desi Nurlita from Abdul Muluk Hospital, Lampung, with the role of acetazolamide in intracranial hypertension, a systematic review. Time and place is yours, Dr. Desi Nurlita.
Assalamualaikum warahmatullahi wabarakatuh. I am Desi Nurlita, General Practitioner from Abdul Muluk Hospital, Lampung. Thank you for the opportunity. I would like to present to you about the role of acetazolamide in symptom of intracranial hypertension, a systematic review. Intracranial hypertension is a spectrum of neurological disorder that is associated with an elevation of the pressure within the cranium. It causes by several etiologies, such as the result of a severe head injury, stroke, or brain abscess, and idiopathic. The cranium is a rigid structure that contains three main components: brain, cerebrospinal fluid, and blood. Any increase in the volume of its content will increase the pressure within the cranial fold. Acetazolamide is a potent inhibitor of the enzyme carbonic anhydrase, known to lower extracellular pH, more acidic. This drug works to cause an accumulation of carbonic acid by preventing its breakdown, resulting decrease of the formation of hydrogen ions and bicarbonate from carbon dioxide and water. It reduces the production of CSF and used in the treatment of hydrocephalus, high altitude disease, and benign or idiopathic intracranial hypertension. Methods. The study is a systematic review. Major online databases is Cochrane Library, PubMed, and Science Direct was searched using the following keyword: acetazolamide or carbonic anhydrase inhibitor and intracranial pressure or cerebrospinal fluid pressure or intracranial hypertension. The limitations are English language abstract, human subject studies, and severity of symptoms. Studies should be published within the last 10 years and are written in English. Prisma flow diagram. Record identified through database searching is PubMed, Science Direct, Cochrane Library. Record after duplicate remove is 1855. Record screened and excluded. After that, we get studies included in qualitative synthesis is 5. This is the characteristic of journal. As we can see, studies by Quiros in 2017. The title is Headache in Idiopathic Intracranial Hypertension, Findings from the Idiopathic Intracranial Hypertension Treatment Trials. This type study is RCT. As we can see, this is the population and intervention. The outcome is headache severity at 6 months. Results: headache disability improved in both treatment groups between baselines and 6 months was significant, but there was no significant difference between acetazolamide and placebo. Studies by Wall in 2014, effect of acetazolamide on visual function in patients with idiopathic intracranial hypertension and mild visual loss. The idiopathic intracranial hypertension treatment trial, this type study is RCT. The outcome is visual field function. Result: improvement in visual disturbances was brittle with acetazolamide than placebo. Studies by Stoga in 2020. The title: The Role of Opening CSF Pressure in Response to Treatment for Idiopathic Intracranial Hypertension. This type is RCT. Outcome is clinical symptoms and cerebrospinal fluid pressure of idiopathic intracranial hypertension. Result: headache was more reported in acetazolamide-treated group. In View 2016, Quality of life at 6 months in the idiopathic intracranial hypertension treatment trials. This study is RCT. The outcome is quality of life using the National Eye Institute Visual Function Questionnaire. The result, we found positive effect of acetazolamide on the near activities, social functioning, and mental health. By Kata in 2015, CSF freezer, pupil edema grade, and response to acetazolamide in the idiopathic intracranial hypertension treatment trials. RCT studies again, the outcome is cerebrospinal fluid pressure response to acetazolamide. The result is significant response of cerebrospinal fluid pressure in the acetazolamide group compared to placebo group. The result, the most common symptom in patients with intracranial hypertension is headache, followed by visual disturbances. In a reviewed study, it was found that administration of acetazolamide in patients with intracranial hypertension was able to reduce the severity and intensity of headache, but there was no significant difference compared to placebo. For visual disturbances seen in other studies, it is known that acetazolamide has a significant effect on visual impairment. Overall, acetazolamide can reduce intracranial pressure compared to placebo and improve the patient quality of life, which includes near activity, social functioning, and mental health. Subscale of this questionnaire. The conclusion, this systematic review indicates that there is sufficient evidence to recommend the use of acetazolamide in patients with intracranial hypertension. The use of acetazolamide in patients with intracranial hypertension may be considered to reduce the severity of symptoms like headaches and visual disturbances. All right, thank you for your attention. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you, Dr. Lisi, for the very nice presentations. There's still no questions till now. Maybe I will ask one question for you. Is the acetazolamide here, do you mean for the idiopathic intracranial hypertension or every type of intracranial hypertension, maybe such as a tumor or hydrocephalus case, or maybe you can explain more on this. Thank you.
All right. Thank you, Doc, for the question. Actually, I was search the intracranial hypertension for all type intracranial hypertension, but when I was searching a literature review, I just got idiopathic intracranial hypertension. So, it must be idiopathic intracranial hypertension, not all the type, because I didn't find apa namanya, the function of idiopathic acetazolamide in another type of intracranial hypertension. Thank you.
Okay, maybe that give us the more information that the effect of acetazolamide mostly only for the idiopathic case, not for the other case, right? Okay, thank you very much for the presentations. Maybe we will get over to the other speaker, maybe Dr. Maria Monica with the title Meningioma with Hemorrhage Presentations and Concomitant COVID-19 Infections, Casual or Causal. Please, time and place is yours, Dr. Maria Monica.
Greetings. My name is Maria Monica, and I am a general physician from Bendan Regional Public Hospital located in Pekalongan, Indonesia. Today, I'm going to present to you my case report titled Meningioma with Hemorrhage Presentation and Concomitant COVID-19 Infection, Casual or Causal. Meningioma usually progress over the years, so the symptoms are usually insidious. Spontaneous hemorrhage of meningioma is a rare presentation of the disease. It is usually very acute, thus usually obscure the initial diagnosis with stroke caused by hypertension. The incidence rate is about 0.5 to 2.5%. The risks and mechanisms on how spontaneous hemorrhage can occur in a meningioma are poorly understood. COVID-19 infection usually gives off respiratory symptoms, But in a study in Wuhan, COVID-19 infection had been shown to cause at least 36% neurological symptoms. It is currently unknown whether there is a causal relationship between COVID-19 and cerebrovascular disease. The research regarding COVID-19 infection and tumoral hemorrhage are very lacking. Most research only covers about COVID-19 infection and pituitary apoplexy. The incidence rate of intracranial hemorrhage and ischemic stroke in COVID-19 infection are 0.2% and 1.2% respectively. Currently, there is no previous study discussing the relation between spontaneous hemorrhage in meningioma and COVID-19 infection. Thus, this is the first study discussing the possible relation between spontaneous hemorrhage in meningioma and COVID-19 infection. Our patient was a 66-year-old woman who came to the emergency department with complaint of sudden alteration of consciousness. Her Glasgow Coma Scale was revealed to be I2, motor 5, and verbal 2. 2 years prior of presentation, she had been complaining of left hemiparesis and progressive headache. The headache was usually mild, but sometimes it can increase to about a moderate headache and interfere with her daily activity. One day prior to admission, she was complaining of worsening headache, fever, and vomitus. And then 17 hours earlier, she decided to go to sleep. Her family said she had not since regained her consciousness. There were no respiratory symptoms. She also had history of dyslipidemia and use of oral contraceptives for over 10 years. This is the plain CT scan of her brain. The left one is the axial view showing an extraaxial mass with intratumoral bleeding attached to the cerebral valves, measuring about 5.8 times 6.0 times 6.5 centimeters. The blood laboratory value showed increase of neutrophil to lymphocyte ratio, increased D-dimer, and shortened APTT. In her chest X-ray, it was revealed that there was a bilateral pneumonia, and upon RT-PCR, her SARS-CoV-2 infection was confirmed. Other vital signs and laboratory values were within normal limit, and our working diagnosis was right falcine meningioma with intratumoral hemorrhage and COVID-19 pneumonia. Upon this diagnosis, we started respiratory support immediately. We gave her a nasal cannula 3 liters per minute and also intravenous dexamethasone 5 mg every 6 hours. Within 1 day, she regained her consciousness to Glasgow Coma Scale 15. We decided to do conservative management because the patient's condition was stable and there was no available resource to do surgery during COVID-19 pandemic in our center. She was hospitalized for 12 days and the in-hospitalization was uneventful. She was discharged after chest X-ray revealed decrease of lung infiltrate. The patient has since not shown up for any follow-up in our outpatient clinic. So spontaneous hemorrhage of meningioma is a rare case and a rare presentation of the disease. In a clinical feature study by Roman Bosniak et al. In the year of 2005, it was revealed that malignant, fibrous, and angioblastic type of meningioma has increased tendency of bleeding. And then there were also significant correlation between intracranial location of the meningioma and the major type of bleeding it can cause. For example, the most common type of meningioma that bleeds was the convexity meningioma, and it can cause for about 49.2% of all subdural hemorrhage. The most common type of bleeding occurred was subarachnoid hemorrhage, and it was usually caused by parasagittal and falcine meningioma. Parasagittal, falcine, and convexity meningioma can also cause intracranial hemorrhage and intratumoral hemorrhage. Intratumoral hemorrhage being the rarest form of presentation. There was also 2 times fold risk of bleeding in meningioma in the age of above 70 years old and below 30 years old. There was no sexual preponderance in this disease. Regarding the mortality rate, in the pre-CT scan era, the mortality was as high as 28 to 50%. But after the CT scan era, it decreased to only 3.9%. Perhaps the development of CT scan and the advancement of medical technology allows us to do faster diagnosis and better treatment. Whether patient can maintain or regain consciousness preoperatively is very correlated to the mortality rate. Patients who remain unconscious have mortality rate for 74.1%, while patients who regain consciousness had a mortality rate of only 3.8%. So our working diagnosis was meningioma bleeding with concomitant COVID-19 infection. To create this working diagnosis, a thorough history taking with physical examination is very important. The clinical presentation is often indistinguishable from spontaneous intracranial hemorrhage caused by hypertension. Both have a rapid onset of neurological deficits and can sometimes be accompanied with alteration of consciousness. History of headache and signs preceding the acute ictus is very important because it showed that there might be a pre-existing structural lesion. To correctly diagnose, we support it with CT or MRI scan. In the CT scan, the lesion will appear to be hyperdense, while on the MRI scan, it will be variable depending upon its age. In our patient, sudden onset of neurological deficit with prior history of headache and left hemiparesis was found. So this suggests that the disease occurred on a pre-existing structural lesion. The mainstay of treatment is control of increased intracranial pressure and mass evacuation, whether it is 1 stage or 2 stage. Some authors suggest that patients with stable neurological deficit can be treated with close monitoring and corticosteroid administration. We cannot find any information regarding COVID-19 positive patients and meningioma surgery. So a study by Fleisserio et al. Suggests the importance of categorizing COVID-19 patients in need of pituitary surgery as either emergent, urgent, or elective. In our case, the patient fell somewhere between urgent and elective because she was stable on steroid without any further neurological deterioration, and there was also no necessary resources available in our center. So we elected to do conservative treatment and close monitoring of the patient. Furthermore, the mortality rate with patients who regain consciousness is only 3.8%. So how bleeding can happen in a meningioma is not yet well understood. However, there were some possible theories that can explain this. The first one, enlargement of blood vessels can cause compensatory weakening of the parietal wall. Thus, the blood vessel will become tortuous and less resistant to blood pressure changes. Second, meningioma could cause angiogenesis and neovascularization. The new formed vessel will be thin and friable and thus more prone to bleed. Third, meningioma can also induce endothelial proliferation that can cause vascular occlusion, distal necrosis, and finally infarct. The infarct will build up the intratumoral pressure and then cause the peritumoral vessel wall to rupture. Fourth, meningeal invasion to the vessel wall will destroy the endothelial cells and can cause the vessel to bleed. Fifth, tumor growth will cause stretching of the subdural bridging vein and thus cause the vein to rupture. Six, there can also be bleeding from the nearby dura mater, which usually form a neomembrane that is more prone to bleed. 7, Meningioma can also induce the release of vasoactive substances from the mast cells, for example, histamine. Histamine can then induce vasodilatation and can cause the blood vessel to rupture. And finally, concomitant vascular malformations such as AVM, systemic illness such as hypertension, diabetes, and dyslipidemia, medication, alcohol, and head trauma were also suspected to have played a role in the bleeding of meningioma. It is important to remember that in this case, the patient has concomitant COVID-19 infection. So perhaps we should study more about how COVID-19 infection could cause cerebrovascular disease. So 82% of all intracranial hemorrhage in COVID-19 infection had at least one pre-existing illness or risk factor. To determine the severity of the COVID-19 infection, some useful prognosis parameter was neutrophil to lymphocyte ratio and coagulation studies such as D-dimer and prothrombin time. Neutrophil to lymphocyte ratio suggests whether or not there is a hyperinflammation, while coagulation studies such as D-dimer suggest whether there is a coagulopathy and fibrinolysis or not. So in our patient, she had history of dyslipidemia, which made her more prone to have at least cerebrovascular disease in COVID-19 infection. Also, we found her to have increased level of neutrophil to lymphocyte ratio and abnormal coagulation studies. Thus, we conclude that in our patient, she at least had some type of hyperinflammation and coagulopathy and fibrinolysis going on. So, how COVID-19 could induce cerebrovascular disease is not yet understood, but there are some possible theories. The first one is viral neurotropism. The SARS-CoV-2 virus can reach the central nervous system through three routes. The first one is retrograde axonal transport via olfactory nerve to the olfactory bulb. The second one is the hematogenous spread through the general circulation and then into the blood-brain barrier. And finally, directly through dorsal vagal complex, which is a circumventricular organ that lacks blood-brain barrier. The SARS-CoV-2 virus will then bind to the human ACE2 receptor expressed in the circumventricular organ and in the cerebrovascular endothelial cells, causing a dysregulation of sympathoadrenal system, vascular autoregulation, and cerebral blood flow abnormality. SARS-CoV-2 infection to the endothelial cells can also cause endothelitis, which will cause microthrombosis of small penetrating arteries that will further cause arterial wall hypoxia and vessel rupture. COVID-19 infection also induce hypercytokinemia. The production of interleukin-1, 6, and TNF-alpha will then cause an increase of matrix metalloproteinase that will degrade the vascular wall integrity. Vascular remodeling coupled with uncoordinated coagulation and fibrinolysis cascade will induce the thrombotic microangiopathy and cause arterial wall hypoxia and vessels rupture. We don't know the exact mechanism on how meningioma occurs. Spontaneous bleeding of meningioma occurs in our patient and whether or not there is a COVID-19 infection relation or not. So in conclusion, hemorrhage associated with meningioma should be considered as a differential diagnosis when examining patients presenting with stroke-like symptoms. Although there is no exact relationship yet, this case report adds to the spectrum of COVID-19 involvement in the central nervous system. A timely diagnosis with holistic multidisciplinary approach is needed to manage such patients. Thank you for listening. Here are my references. If you have any input or comments, please feel free to drop an email into the email provided here. Thank you very much.
Okay, thank you very much, Dr. Monica. It's very good presentations and a good case for us. But maybe I have one question for you. What do you think about the case of your case is already still response to the steroid therapy? In what case of meningioma with hemorrhage that you think that the emergency surgery is needed for the patients that will benefit more than conservative treatments? Thank you.
Thank you very much for the question, Dr. Kevin. Well, according to the literature study, usually patients who came with sudden deterioration of consciousness and upon CT scan revealed to have meningioma, they are considered to be urgent to do surgery. But because in this case, we are currently having a COVID-19 pandemic situation, there were more considerations to be made. And in our center, we cannot do surgery with ventilator for patients who have COVID-19. So we did not perform it. And upon literature, the decision on when we stop using dexamethasone and when to should we stop and do surgery is not yet clear. But most literatures tend to say that if the patient cannot regain his or her consciousness, that means it is time to do surgery. But if upon dexamethasone administration that she can regain her consciousness, then there will be a decrease of mortality rate. Thus, the literature suggests it can be delayed. Thank you.
Okay, thank you. Okay, there is one question for you. Is there any chance that COVID-19 infections might be just a confounding factors for the presence of meningioma with hemorrhage presentation in this case? From Dr. Ariandito.
Thank you very much, Dr. Ariandito, for the question. Yes, so in this case, we are still confused on whether or not COVID-19 can be somewhat of a risk factor or whether it is only a confounding factor. It is why we titled the case to be causal or casual. So it can still be just casual presentation that, and COVID-19 has nothing related to the spontaneous bleeding of the meningioma. But it is very important to remember that because we are here in the pandemic, and so even if the COVID-19 is only a casual and confounding factor, but it can also affect how we can do surgery and our decision to do surgery. Thank you.
Okay, thank you for the answers. Maybe you can contact the patients and do the surgery and we get the pathological results. Maybe it can conclude what's happened with the patients. Thank you very much. Maybe we can go to the next speaker. And Dr. Lucas Galileo, a neurosurgeon from Department of Neurosurgery, Dr. Hasan Sadikin General Hospital Bandung, Indonesia, with the topics correlation analysis between diameter of intravertebral foramen on magnetic resonance imaging to radiculopathy symptoms of lumbal foraminal stenosis patients. Time and place is yours, Dr. Lucas.
Good morning, I am Dr. Lucas Galileo. I am neurosurgeon from Hasan Sadikin General Hospital, Medical Faculty of Pajajaran University. Thank you for the opportunity today. I would like to present our study entitled Lateral Extracavitary Approach, LECA, and costotransversectomy in thoracic region neoplasm, a case series with literature review. As we know, various posterolateral approaches are widely used to access anthrothoracic spinal canal. Pathology. The lateral extracavitary approach, LECA, and costotransversectomy are two posterolateral approaches that avoid entrance into the pleural cavity and facilitated anterior decompression. The indication of outcome of each of these approaches have not been fully defined in the literature. Some literature said that LECA has more complex perioperative complication than costotransversectomy, although it was used to treat more complex and extensive pathology. The objective of this study is to present our experience in our department and surgical outcomes by comparing with previous literature to achieve better outcome. There are many previous literature, the supporting journal to our study. The very study has been published comparing the advantages, disadvantages, and post-operative outcomes of LECA and costotransversectomy to the anterolateral and anterior thoracic region. Much of the present literature consists of study with small sample size, comparing only a limited number of approaches and limited number of surgical indication. Moreover, the specific of the surgical procedure have not been defined clearly. In the present study, we have attempted to answer many of these questions and to provide surgical and outcome information to address these difficulties. This is the previous literature. It is from the Cleveland Clinics in Ohio. A retrospective chart review was performed for all Cleveland Clinic patients undergoing LECA and costotransversectomy between January 2015 till December 2020. The indication operation mostly are osteomyelitis case in LECA and tumor cases in costotransversectomy. The blood loss in LECA is higher than in costotransversectomy, but not statistically significant. The length of hospital stay in LECA is higher than in costotransversectomy, but not statistically significant also. The complications of the procedure are divided into intra and post-operative complications, but there are no statistically significant between LECA and costotransversectomy complication. From complication by indication, the disc herniation, fracture, tumor, osteomyelitis, scoliosis, and kyphotic are the most indication that can produce complication. So I will proceed to our case series. The first case series is about a 70-year-old man with chief complaint the radiating pain from his back to both of his foot since 1 year prior to admission with visual analog scale 6/10. There is no worsening of motoric, sensoric, and autonomic function. Other clinical examination and laboratory finding within normal limit, and the patient underwent contrast lumbosacral MRI. So we diagnosed the patient with space occupation lesion extradura at level thoracal 12 due to suspect schwannoma, and we differential diagnose with metastatic. And we perform LECA procedure, tumor section, and posterior stabilization. Intraoperative finding after we draw the incisional design, curved linear incision. We dissect the muscle layer by layer until we found the lamina, and then we perform posterior stabilization with pedicle screw, 3 level on the right side and 2 level on the left side. And then we perform laminectomy, and after that we perform the LECA is about 8 cm from the head of rib. After that we perform durotomy and we resect the tumor delicately. And then after the tumor being removed, we perform duroplasty. The outcome of this surgery, after the surgery, the radiating pain was improved significantly and early mobilization was done. The patient was discharged using wheelchair, follow-up 1 month after surgery without post-op complication. In perioperative finding, we found that blood loss is about 1,000 cc and hospital stay is about 9 days. The second case is about a 43-year-old man with chief complaint weakness of his both lower extremity since 7 months ago, preceded by radiating pain and numbness on his back since 1 year ago with visual analog scale 5/10. Other clinical examination and laboratory finding within normal limit. The patient underwent contrast thoracolumbar MRI. We diagnosed the patient with space occupation lesion intradura extramedullary at thoracal 7 until 9 due to suspect schwannoma. Is our first diagnosis, and we perform LECA, tumor section, and also posterior stabilization. The intraoperative finding is similar to the first case. The outcome after the surgery, the weakness and radiating pain were improved significantly, and early immobilization was done. Follow-up 1 month after surgery without post-operative complication. The perioperative findings, the blood loss is about 1,100 cc. Hospital stay is about 10 days. The third case series, we report that 43 years old woman present to our institution with chief complaint weakness of the lower extremity 4 months ago, preceded by radiating pain and numbness on her back since 6 months ago, with visual analog scale 3/10. Other clinical examination and laboratory finding within normal limit, and the patient underwent contrast lumbosacral MRI. We diagnosed the patient with space occupation lesion intradura extramedullary at thoracal 10 to 11. Due to suspect meningioma, we differential diagnose with schwannoma. And then we perform costotransversectomy, tumor resection, and also posterior stabilization. The patient is positioned in the prone position, and we draw the curvilinear incision. After we dissect the muscle layer by layer, we found the lamina, and we perform posterior stabilization with pedicle screw, 3 level in the right side and 2 level in the left side. After that, we perform laminectomy, and we cut the rib about 6 centimeters from the head of rib. The outcome after the surgery, the weakness and the radiating pain was improved significantly, and early immobilization was done. Follow-up 1 month after surgery without post-op complication. The perioperative finding, the blood loss is about 800 cc. Hospital stay is 8 days. The last case in our study is about 41 years old woman presented to our institution with chief complaint weakness of lower extremity since 5 months ago. Other clinical examination and laboratory finding within normal limit. Then the patient underwent contrast thoracolumbar MRI, and we diagnosed the patient with space occupation lesion intradura extramedullary at level vertebra thoracal 8 due to suspect meningioma, and we perform costotransversectomy, tumor section, and also posterior stabilization. The intraoperative finding is similar to the third case. The outcome after the surgery, the weakness was improved significantly, and early mobilization was done. Follow-up 1 month after surgery without post-op complication. Perioperative finding, the blood loss is about 700 cc, and hospital stay is about 7 days. The discussion of our studies about the extension of surgical exposure. SLECA provides greater exposure and is likely better suited for more extensive pathology. Previous study from Kisteri in 2015 stated that LECA provides wider exposure and is likely better suited for more multi-level pathologies. This is appropriate with the result of our study, and Chandra et al. In 2014 say that extended costotransversectomy to achieve circumferential fusion for pathology causing thoracic instability is also appropriate to our study. And the second point of the discussion, the comparison of intraoperative blood loss were greater in patients who underwent LECA compared with costotransversectomy. The study from McCormick shows that blood loss is higher in LECA than in costotransversectomy. And the third point of discussion is comparison of the hospital stay is greater in patients who underwent LECA compared with costotransversectomy. Wiggins et al. In 2016 say that the hospital stay is about 15 days in LECA and 8 days in costotransversectomy is also appropriate to our study. The limitation in our study, scientifically, limitation of the number of samples, variation of samples, pathologies, the different surgical preference from neurosurgeon, statistically more number and variation sample, also continuous follow-up period was expected to avoid statistical bias and to get better result. Both LECA and costotransversectomy are effective options for the treatment of ventral and ventrolateral pathology of the thoracic spine. LECA was associated with increased blood loss and longer hospital stay than costotransversectomy. The choice of one over the other should be predicted on surgeon expertise, the extent and type of pathology, and the reconstruction requirement. So the recommendation of our study, we have to identification of thoracic region neoplasm, the location, the substrate, the number, the extension of meshes, the important structure around the tumor, the patient comorbidity and facility. After that, we can determine which kind of posterolateral approach we will choose, the LECA or costotransversectomy. In the end, we can make informed consent to the patient about the outcome of the surgery, and then we can make further perioperative planning for the patient. Thank you for your attention.
Thank you very much, Dr. Lucas, for the very nice presentations and a nice approach for the spine surgery. There are two questions for you from Dr. Harley Joy. First one, what are the postoperative pathological findings for each case? The second one, would there be any risk of pedicle screw loosening in long-term follow-up, or would it be necessary to increase the possibility of fusions using other modality other than pedicle screw?
Okay, thank you, Dr. Kevin. Can you hear my voice?
Yes.
Yeah,
Really?
I will answer the first question, maybe the postoperative histopathological finding of these cases. Our cases, all of them are intradura extramedullary tumor. So the pathological result is meningioma and schwannoma. But I didn't show the pathological result. I'm sorry. But as I know, I remember that this is schwannoma and meningioma.
Okay.
Okay, and for the second question, the complication of pedicle screw loosening, I think is, in my opinion, there will be the risk. But after we follow up the patient until the 6 months and the readmission rate after the 1 month, there is, and the patient underwent the X-ray control, there is no sign of loosening of the pedicle screw from this patient. Yeah. We follow up the patient the first week, the first month, the 3 months, and the 6 months, and we perform the X-ray, and there is no sign in X-ray about the loosening of pedicle screw. And the question is necessary to increase the possibility of fusion. Yeah, in this case series, our division didn't perform the anterior graft to the patients because we didn't perform the corpectomy to the patient. We didn't perform the vertebral column resection, and in our division decide that this is sufficient. Only perform the pedicle screw in the posterior fusion, not the anterior fusion with anterior graft. But if in the near future there is a sign of the non-fusion condition, maybe this we will determine we will consider the patient. It is okay to do perform anterior graft or no to do perform anterior graft. But until now, the posterior fusion with a pedicle screw and stabilization, it is sufficient. Thank you, Dr. Kevin.
Thank you very much for the answers. Maybe I have one question for you. Do you deflate the lung during the procedure?
No. Our division didn't deflate the lung. Only perform the skeletonize the rib, cut the rib. If LECA is farther than 6 centimeter, and if we perform the costal transfectomy, we cut the rib lesser than 6 centimeter. We didn't deflate the lung. So the complication to cardiopulmonary complication is very small.
Okay, thank you. Thank you very much, Dr. Lucas, for the very nice presentations. Okay, we are going to the next speaker for the session, maybe the last speaker. Wait. Maybe Dr. Made Buana Putra. Is Dr. Made here? Okay, with the topics initial experience of intracranial pressure monitoring for severe traumatic brain injury cases in Bali. Time and place are yours, Dr. Made.
Good day to all of you. It's an honor for me to be able to present our experience here and care series here in this very extraordinary event. So thank you for having me here. My name is Made Buana Putra. I'm from Sanglah General Hospital, Bali, Indonesia. So what I'm going to present is actually a very simple topic about our initial experience in actually ICP monitor for severe TBI cases in Bali. So what we're going to discuss about today is actually I'm going to go over with some basic knowledge about ICP that we already know, and we're going to see what are the types of intracranial pressure monitoring that is being used, more sophisticated one, and so we can compare it with what our experience here in Bali. So as for the introduction, so this is severe TBI cases, as we know, comprise of about 5 million cases per year all over the world, and a lot of these kind of cases actually happen in the low middle income country as here in Indonesia. And intracranial hypertension is found to be like about 40% to 60% of all severe TBI, and as one of the major factor of death in all cases with severe TBI. And one of main possible management target, as we know, is the ICP control. So we really have to control the ICP in managing patients with severe TBI. And how to know the ICP, of course, with ICP monitor. And the proportion of ICP recording greater than 20 millimeter mercury is actually highly significant in predicting outcome of the patient with severe TBI. And just a little quick overview about the ICP monitor. ICP waveform, actually the ICP is, if we are going to monitor the ICP, then we actually have to consider the ICP waveform, as we can see here, which is already being described by Lundberg. There's actually they describe that there's three types of ICP wave, as we can see here in the diagram, which we can interpret that the patient is actually having just a normal waveform with perhaps a cerebrovascular and periodic breathing rhythm, or if the patient is actually really having a high intracranial pressure. And this is just several types of ICP monitoring placement that can be done, from the sophisticated one until the very simple one. The one that is considered as still one of the gold standard for ICP monitor is actually still the intraventricular device that is coupled with a pressure transducer. So if we do it without the pressure transducer to the monitor, then might be a less of the gold standard. And as we see here, this is the pros and cons of putting the ventricular catheter. And as we can see here, the negative side of putting the ICP monitor intraventricular is actually there's a risk of misplacement, especially that we know that we use the more freehand technique, and the range of rate of malposition is actually from 4% to 20%, which further can cause an increase in risk of hemorrhage, which can happen with less than 2%. With the risk of obstruction, even though that we already put the ventricular drainage correctly, there's always a risk of obstruction after the placement of the ICP monitor into the ventricular system. Risk of infection is actually less than 10% and increase after 5 days. So that is actually one of consideration as to how long we should put the ventricular catheter in place. In the positive side, it is actually relatively cheaper than any other kind of monitor, the ventricular monitor, and it actually considered as the one of the most accurate among all of the other types of monitor, and it can measure overall ICP instead of just regional or local ICP. And also the biggest advantage so far for using the ICP monitor intraventricularly is actually the ability to drain the CSF as a measurement to decrease the ICP. As we can see here, this is actually a simple diagram about the procedure of the ICP monitor, and the picture on the right side is here we can see that the one that is the standard of the ICP monitor actually should comprise of the transducer to the monitor, so we can see the ICP waveform and we can evaluate the ICP continuously rather than just see it intermittently about the amount of ICP. And then we can also drain the ICP to drain the CSF to the reservoir, and then we can take the CSF as sample for further evaluation. And this is our study and our experience series about the custom-made ICP monitor that we use here in Bali as the part of management of the severe TBI. And indication of putting the ICP monitor itself, actually this is quite the same as the indication that is in the guideline of the Brown Trauma Foundation. So all the patients with a GCS at 3 or 8, salvageable patient, and with our normal CT scan, that is not really an indication for the surgical, like decompressive or maybe evacuation of the mass lesion, then we put the ICP monitor. So this is the simple tools that we use. A lot of time we use the manual cranial drill. Sometimes we have the privilege to use the automatic drill, and just as you can see, just a standard set of neurological set that we use in daily basis. And also the procedure itself is very standard that we already know. So we use the core point as the place of insertion of the ICP monitor and put it in the frontal horn, the lateral ventricle, and usually we use the nasogastric tube as we can see here. So it's very simple that we can do it everywhere. Nasogastric tube with the number is like number 10 or perhaps number 8. Depends on the condition of the patient, on the availability of the NG tube itself. And sometimes we have the privilege of using the extraventricular drainage to be used as a ICP monitor, and then we just modified it a little bit so we can use it as the. So as we can see here, it's actually a very simple setup. After we put the ICP monitor, then we can set this up in the ICU or wherever we take the patient to. And this is a very simple setup. As we can see here, that there's two setup. One is actually going to be the ICP monitor setup, and one is actually the EVD setup to drain the CSF if there's any increase of intracranial pressure. And in the middle picture, as we can see here, there's a reservoir, the urobag, and the just being put in the side of the patient. And there's actually a three-way. One is connected to the intracranial pressure system, ICP monitor system, and one is connected to the extraventricular drainage system. So first we put the system into the ICP monitor system. If the CSF is actually, or the ICP is actually getting higher than 22 millimeter mercury, then we can put the system into the extraventricular drainage and then drain the CSF into the urobag. So it's actually a very simple system without any monitor or any kind of transducer. The point being here is actually one of the problem is that we cannot see the ICP, we cannot evaluate the ICP continuously, we cannot evaluate any kind of waveform and anything. It's just a really simple setup that really helps us in managing patients with severe TBI. So this is the result of some of our patients. Actually, there's a certain patient here that is included in this study with various kind of intracranial lesion going on. One with brainstem hemorrhage, one with intracerebral hemorrhage in the corpus callosum, and most with severe diffuse injury, and with GCS actually all lower than 8 in this case. And this is the result of our study and our series or mini series here. So this is all the study. Length of stay is so a lot of the patient is actually not managed to survive. Some patients actually survive. I mean, if they survive, they're going to have a real long treatment, as we can see here, with the initial ICP, some with a really high ICP, some with just a not little to normal ICP, with complication. There's actually a two complication, hemorrhage complication, and fortunately no infection as per this last patient. And this is intraoperative bleeding and duration of operation is seen as in the operative report. And this is the summary of our finding. With the mean operative time is about 43 minutes, and mean operative bleeding, intraoperative bleeding is actually only 5 cc, and mean initial ICP is about 19 centimeter water, and average length of stay is about 60 days. So some ways are really long length of stay in the hospital. With a complication of hemorrhage in 2 patients and fortunately no infection. And the problem is when using this kind of custom-made ICP monitor, being a relatively cheap option for as a ICP monitor is actually really difficult to evaluate the ICP continuously. So all we can do is actually just evaluate the ICP intermittently, and one point of evaluation instead of ICP trend, as we know that we should actually able to see the ICP trend instead of just seeing it at one time to the other time. And evaluation of ICP waveform is really not possible using this kind of method. But this is actually this really simple procedure with just basic equipment. So without any kind of sophisticated method of putting the ICP monitor and several limitations that we have to admit regarding the evaluation of ICP, that we cannot really appreciate any kind of trend of ICP or any kind of waveform of ICP, that we only able to evaluate the ICP intermittently, but still it is a relatively safe and reliable method to objectively measure the ICP. And adaptation and modification with being used here in our place with the absence of any kind of advanced ICP monitor. So thank you very much once again for having me. Wish you all a good day and good health. Thank you.
Thank you very much for the good presentations, Dr. Made Buwana Putra. There is one question for you from Dr. Ariandito Widinugroho. So basically, this is a modified EVD, external ventricular drainage, utilized to monitor ICP, right? Should there be any difficulty in accessing the ventricles when no ventricular dilatation identified? I'm worried about the possibility of injuring the cortex in doing the procedure. Thank you. Maybe that means how many attempts, or do you have any experience that false routing the insertions of the external ventricular drainage in these patients? Thank you.
Yeah, thank you very much for the question, Dr. Arianito. And so, yes, it is really hard, especially in patient with CP-TBI, as we know that the brain is really dim. And then the ventricle, sometimes it's, unlike the hydrocephalus cases, it's really slit ventricle. So the difficulty is actually because we're using a freehand technique to insert the EVD itself. Just one caveat that we use here, actually we really have to use the CT scan preoperatively to measure the trajectory and then the length of from the inner table into the ventricular itself, because sometimes it doesn't really goes into like what we used to do, like 5 centimeters from the dura, or goes like into the usual trajectory of the cohort point. we really have to evaluate the trajectory of the ventricular system based on the preoperative CT scan. I think that really helps. Sometimes we have to do a borehole like more to the medial instead of using like a 3 centimeter from the medial like we used to do, just to make sure that the just insertions like strike insertion, perpendicular insertion can goes into the ventricular system. The attempts we usually use like 2 attempts. Sometimes if really difficult, like 3 attempts. Yeah. But not really that much attempts. Thank you very much.
Okay, thank you, Dr. Made. I have one question for you. How do you decide that the patient doesn't need any ICP monitoring anymore, so you can off the drainage or the ICP monitor for the case? I saw
Thank you
there
very much.
is low opening pressure also in your case. I see.
Yes.
So,
Okay. Thank you very much for the question, Dr. Gavin. So what we use here is actually really really similar to what we found in the CB consensus. So if it's the ICP is acceptable for more than 72 hours, and even though the GCS is still like still in below 8, but if it's acceptable after 72 hours, then we can actually it is safe, I think, to put out the ICP monitor. But the longest time I think it's like 7 days, because what we found after the 5 days or after 5 days or 7 days, there's an increased risk of infection. So I think after 7 days we evaluate the patient again to see if the ICP monitor is still needed or not.
thank you very much, Dr. Made Buana Putra. Okay, maybe that's all for the presentation today in this young neurosurgeon sessions. If there is no other questions more for the sessions, I will close the session now. Thank you for your attention, for attending. I hope these presentations from the speakers in this session can be benefit from you all, for you all that follow the sessions. Maybe time and place I will give to the committee of the ACNS.
Thank you, Dr. Kevin. Thank you for leading this session. We thank all the audience for your attention. Thank you for all the speakers. And now we will have 10 minutes break and we'll continue for the next session, which is Young Neurosurgery 4. Thank you and have a nice break.
Thank you. Lift ya, boleh. Sudah boleh lift ya nanti kan?
NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures.
Anaknya nggak makan apa? Nggak mau makan dasi. Oh iya. Kayaknya kopi.
Good afternoon, Dr. Thomas. Can you hear me?
Yes, good afternoon. I can hear clear. Thank you.
Yes, sir, we can hear you. Good afternoon for all the participants. Now we will start the second session for Young Neurosurgery 4. This session will run for about hour and a half, including the discussion part. In this session, we have 6 different topics and 6 different speakers. And this time we have Dr. Thomas, neurosurgeon, to lead the session. Allow me to read Dr. Thomas' CV first. Okay. Dr. Thomas is a neurosurgeon at Siloam Hospital Bogor. A brief educational background from our moderator. Dr. Thomas finished his Master of Medicine in Neurosurgery at 2013, and at 2015 he completed his neurosurgery program. Dr. Tommy, this session is yours to lead.
Okay, thank you, committee. So this evening, I would like to say thank you for the committee of the second ACNS Virtual International Conference. So I will lead this or moderate this session. And this session is going to be 6 presentations. And this is a YNS session. So I would like to call Dr. Teku Ari Hidayat with a title Close Reduction of Unilateral Facet Locking in Cervical Dislocation Fracture. How do we do it? A case report. So Dr. Teku Ari Hidayat is ready for his presentation?
Yes, good afternoon, Dr. Tommy.
Yes.
I believe that I have sent the pre-recorded video to the committee. Can you just play the pre-recorded video?
Yes, we will play the video recorded now. Thank you.
Okay, let's start the video. Thank you.
Assalamualaikum warahmatullahi wabarakatuh. My name is Teku Ari Hidayat. I'm a neurosurgery resident from Gajah Mada University. Today I would like to present a case report on close reduction of unilateral facet locking in cervical dislocation fracture. A 49-year-old man was involved in a high-velocity motor vehicle accident. He was ejected and landed on top of his head, complained of pain at the low cervical area, and had immediate weakness of the lower extremities, accompanied by numbness below chest area. He was immobilized in a cervical collar and on a spine bone, and was brought to Sarjito Hospital for further evaluation. Physical examination upon arrival at Sarjito Hospital revealed abdominothoracal breathing, paresis of the upper extremities from C6 to T1, paraplegia, and decreased sensation to light touch and pinprick below C6 dermatomal areas. Deep anal pressure negative, voluntary anal contraction negative, bulbocavernous reflex positive. As you can see from this ASIA classification, the patient had decreased motor function below C5, decreased sensation below C6, both to pinprick and light touch, deep anal pressure negative, voluntary anal contraction negative, and this patient had neurologic level of injury on C6 with complete type spinal cord injury. From the CT scan, we can see that there is a malalignment on C6 to C7. And if we take a closer look from the CT scan 3D, there is a bilateral laminar fracture on C5, dislocated fracture of the left C6 to C7 facet, and perch facet on the C6 to C7 on the right side. If we convert all of our findings into the subaxial injury classification, we would get a total point of 8, which means that the patient needs a surgery. We diagnose this patient with spinal cord injury, cervical level, neurologic level of injury on C6, complete type ICE, unilateral facet dislocation of the 6 to 7 cervical vertebrae, perch facet of the 6 to 7 cervical vertebrae, and fracture of the lamina of the 5th cervical vertebrae. An attempted close reduction with cervical traction with external maneuver was successful. These are the timeline to the event. So the patient had a high velocity motor vehicle accident. He was then admitted to a nearby hospital where he then get an initial treatment and CT scan examination. He was then referred to Sarjito Hospital. As soon as he gets to the Sarjito Hospital, he was reassessed and had a further examination, and then a close reduction and extra maneuver was performed. The following day, the patient had an MRI and was then planned for anterior cervical discectomy and fusion with anterior plate fusion. This is the data from one journal where it stated that of all cervical dislocation injuries, 20% occurs on C2 to C5, 75% occurs on C5 to C7, 5% occurs on C7 to T1. There are several options for cervical traction. The one we use is Gardner-Well tongs, where we place the pin directly above meatus acousticus externus, around 3 to 4 centimeter above pinna for neutral position, 3 centimeter posterior to that for flexion moment, 3 centimeter anterior to that for extension. If there is normal alignment, traction is being used just to stabilize the injury. And to compensate for ligamentous instability, we use 5 pounds for the upper cervical spine or 10 pounds for the lower level cervical spine. In Handbook of Neurosurgery from Greenberg, the initial weight used is 3 times cervical vertebra level, and then we would increase it by 5 to 10 pounds at every 10 to 15 minutes. And some say do not exceed 10 pounds per vertebra level, or some would even say not more than 5 pounds per vertebra level under most circumstances. And if there is a case of unilateral lock facet, we should apply an external maneuver with flexion plus rotation towards the site of the lesion. If there are a bilateral lock facet, we should apply a hyperflexion external maneuver. These are some key points to the procedure. The patient must be awake, alert, and cooperative. And the posterior pin placement will apply a flexion moment to the cervical spine. An anterior pin placement will apply an extension moment to the cervical spine. A small amount of weight, usually 5 to 10 pounds, is used initially to avoid over-distraction. To reduce facet dislocation, a flexion moment helps unlock the dislocated facets. This can be achieved by posteriorly placing the pin or by raising the height of the pulley. And if over-distraction occurs or neurologic deterioration occurs, the weight should be immediately removed. As you can see from the picture below, after giving enough traction moment or traction weight, and then applying an external maneuver, the dislocated facets will return to its normal position and restore normal alignment. This is another example from one journal where there is, as you can see, a malalignment on C6 to C7, and then they apply an external maneuver by rotating the head towards the side of the lesion to a 30 to 40 degrees angle, and they achieve a normal anatomical alignment. This is what we do in our institution. So after you decide the place of the pin, it's important to remember that don't place the pin or don't bore the pin too hard, as you may breach the inner table. So in the case of unilateral dislocated facets, we should apply the pin and place the pin 3 centimeters superior and 3 centimeters posterior to the pinna. And after that, an initial weight of 2.5 kilograms is placed, and we gradually increase the weight every 15 minutes until we have our desired weight, which is 10 kilos. It's important to remember that facets should be distracted to a perch position before attempting manipulative reduction. This is a video showing how we perform the external maneuver. An external maneuver is applied by using a gentle torsion with flexion rotation towards the side of the dislocation side, and in this case to the left side. After we achieve the release or the unlocking of the dislocated facet, a reduction is achieved at 10 kilos in our case, and then the weight is gradually decreased to 4 kilos for immobilization. We would know that the dislocated fracture has been released or unlocked. Usually there is a sensation of pop or click as we apply the external maneuver.
Yang kiri, yang kanan. Oke, mulai dikit lah ya. Dikit ya. Oke, betul Pak. Oke. Nah, dikit lah ya.
Yeah, as you can see, we apply a traction and perform a flexion rotation movement to the left side, to the dislocated side, with a 30 to 40 degrees angle. This is the fluoroscopy from the pre-reduction. We can still see that the alignment on C6 to C7 is not normal. After we apply traction with 10 kilo weight, plus applying an external maneuver, the alignment is restored to its normal position. The following day, the patient had an MRI, and the post-reduction MRI shows a disc herniation on the 4th to 5th and 6th to 7th cervical vertebrae with spinal cord contusion at the corresponding level. The patient was then scheduled for anterior cervical discectomy and fusion with anterior plate fixation. For conclusion, we felt that close reduction with Gardner-Weil tongues, cervical traction, followed by external maneuver, will help neurosurgeons in rural areas, not to mention that it's a very simple technique. This technique will help to immobilize and help achieving reduction with satisfactory outcome. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Ari, for nice presentation of close reduction in the case of locking facet joints. And there is a question from the chat. So I would like to open a question, only one questions for this presentation because of time. So Dr. Teguh Ari, question from Reza Mawardi. Thank you for the presentation. He would like to ask about what is the consideration to perform close reduction without performing MRI beforehand?
Okay, thank you, Dr. Reza, for the question. From what I understand is that even if we have the facilities to perform emergency MRI, in reference or literature that I have read, it is very important to achieve immobilization and spinal cord decompression as soon as possible. So imagine if we have to do the MRI, not to mention that the duration of MRI, and also not to mention that the lack of facilities in some of our hospital in Indonesia, it will take so much time. So in this literature that I have read, even if they have those services, they would still prefer to do the close reduction first, and then if it was successful, they will perform the MRI to see whether there is a traumatic hernia nucleus pulposus before undergoing the next operative procedure. Thank you.
Okay, thank you for the answer. So the setting is for rural area, probably MRI facility is not provided. So I think it is a common logical thing. But maybe I have to mention one thing that I saw that in the case, the Philadelphia collar is a little bit too large because the chin position is too anterior on the collar. And also, maybe this is my question, how do you, I mean, if someone with a spinal injury coming with like numbness from the thoracic area, usually it is a sign of a spinal injury, and doing maneuver by close reduction without imaging, I think for a legal standing, it would be might might cause a problem because you don't have the evidence that the contusion of the spine is not caused by the maneuver. I think it has to be mentioned in detail. So thank you, Dr. Ari. We will continue for the next speaker. The next speaker is Dr. Julius Hermanto with the title of Identification of Factors Predicting Diabetes Insipidus Occurrence Following Endoscopic Transsphenoidal Surgery for Pituitary Adenoma. Is Dr. Julius here?
I'm here. Just allow me to share my screen.
Okay. Please, Dr. Julius, the screen are yours. Thank you.
I'm sorry, I'm still unable to share my screen.
Maybe committee can help.
Please try again, Dr. Julius.
Okay.
Good evening, are my slides clear? Okay, thank you very much for the committee for the opportunity for me to present my research. Today, in these occasions, I would like to present our research with the title of Identification of Factors Predicting Diabetes Insipidus Occurrence Following Endoscopic Transsphenoidal Surgery for Pituitary Adenoma. Before I explain about our research, I would like to explain a little bit about diabetes insipidus itself. So diabetes insipidus, or DI, is a group of signs and symptoms caused by insufficiency of antidiuretic hormones, or we also call it vasopressin. As we know, physiologically, vasopressin is being produced by hypothalamus and being secreted through a posterior part of pituitary gland and being circulated to in our body, and mainly act in the kidney, which mainly function to promote the urine concentration, so to concentrate the urine. So in the conditions where there is a low concentration of vasopressin by any cause, whether central or nephrogenic, the circulating vasopressin may be very low, and therefore there is failure of kidney to concentrate urine. So as a result, a low concentration of vasopressin will cause of excess fluid and electrolyte excretions and promote increase of serum osmolality. As a result, typically patients with diabetes insipidus will present with the symptoms of polyuria, or in a clinical situations they also experience a polydipsia, feeling thirsty and a lot of water. And this finding is typically commonly occur in the patients underwent transsphenoidal surgery. So this is a representative image how transsphenoidal surgery is being performed, in which we perform through using endoscope through the splenic sinus and exposing cellular floor and performing tumor excision or removal through this area. So it's actually a very common complication from following transsphenoidal surgery. This occur about 60%. And nevertheless, majority of postoperative DI is actually a transient case and not a permanent one. And theoretically, the theory behind it is due to a temporary dysfunctions of a hypothalamus pituitary axis due to a cervical trauma or particularly strain of a pituitary stalk during the removal of the adenoma itself. So this is a representative CT scan of our patients in which there is a hypodense lesions in cellular region, and this is also the representative procedure how we perform tumor removals. So the problem is the inaccurate identification and management for this kind of patients may cause various complications and may prolong the length of stay in the hospitals, and also may interfere the patient quality of life in the future. So the methods of our research is actually collecting all the adult patients with the pituitary adenoma that underwent endoscopic surgery. During this time period, we are conducting our research at our hospital, Hasan Sadikin Hospital in Bandung. As a result, we obtained a total of 51 patients with the pituitary adenoma. And the most important of all in this part of method is how we define diabetes insipidus. So prior to this publication, DeVries et al., there is many variations and the definitions about diabetes insipidus. By using this publication, we modified and applied how we define diabetes insipidus and the conditions mimicking diabetes insipidus. First of all, as we know, we have to define the normal conditions. Normal conditions, as being stated in many literatures, the urine output is within 0.5 to 1 milliliter per kilogram body weight per hour, while there is no increase of serum sodium levels, and the urine osmolality within the normal range. While the transient DI or patient have a postoperative DI will have a more higher urine output, more than 2 milliliter per kilogram body weight per hour, and also tend to have hyponatremia postoperatively, and with a low urine osmolality. While the fluid overload, they tend to have only high urine output, while the other parameters tend to fall into the normal range. So as a result, this is a characteristic of the patients in this study. So the mean age of the patients is around 40 years old. The proportion between male and female is about similar, around 50%. And most of the patients typically appears with a visual field disturbance, as we can see in this image. This is a representative perimetry examinations from our patients. Another symptom is headache, and as being noted in the literature, most of the case actually non-functional adenoma. So actually, the hormonal disturbance is quite uncommon, around only 20%. And the tumor diameter in our series is around 2.9 centimeter at the largest diameter. And as you can see here, there's a tendency of increasing postoperative serum sodium levels compared to the preoperative one, and also the tendency of having high urine output postoperatively. So because we would like to determine kind of prognostic factors, some factors have to do in the logistic regressions. So before that, have to classify diameters into a certain cutoff. So before I determine or see whether tumor diameter can be used as a good cutoff point, I perform analysis to see the distribution of tumor diameters in the patient with the diabetes insipidus and the patient without diabetes insipidus. As we can see in this figure, the patients with diabetes insipidus tend to have a higher or larger tumor diameter compared to a patient without diabetes insipidus. As a result, we follow the analysis with the ARC curve, and we found the ideal cutoff for tumor diameter in this study is around 2.8 centimeters with a good high sensitivity and high specificity. Then I continue the examination or analysis using a bivariate analysis, and I found that there is 4 candidates that is potentially become a predicting factor for diabetes insipidus occurrence. One of them is visual field disturbance, hormonal disturbance, tumor diameter, and the type of tumor resections. As we can classify these factors, 3 of them will belong to preoperative factors, and 1 of them belong to intraoperative conditions. Then to further identify the reliable factors, we conducted a multivariate analysis, and we found among the preoperative factors, the visual field disturbance, hormonal disturbance, and tumor diameters, the tumor diameter itself, which particularly if the tumor size more than 2.8 centimeter, was associated with a higher risk of having transient DF postoperatively, about 31 times compared to a smaller tumors. And patients that underwent subtotal resections were also associated with the lower risk of having transient DI postoperatively. As discussions, so in the literature and also in our series, most of the large adenoma were non-functional adenoma that gave symptoms mainly to the prism, to the surrounding structures, either to the optic nerve and optic chiasm, as we can see in this image from Roton. Pituitary gland is located. There's an important structure nearby. When it's enlarged by the tumor, it will compress surrounding structure. And the star compressions by tumor size, extensions, or size of cella may be different between individuals and therefore may cause different symptoms between individuals. And in the literature is also being reported that adenoma with extensions to the supracellular regions is also associated with a higher incidence of postoperative DI, probably due to influence or damage to the hypothalamus itself. And in our research, and what I like to take home message is it's important to define and distinguishing DI from other conditions that actually very mimicking DI. It's necessary for us to ensure a proper treatment for postoperative patients. Particularly perioperative fluid overload is very difficult to distinguish from DI. So we just by clinical symptoms. Therefore, we need to add more examinations such as serum sodium levels and also serum or urine osmolality to distinguish whether the patient is actually having a postoperative DI, which require certain treatment, for example, vasopressin analog, or patient is actually having a perioperative overload, which can be managed by fluid restrictions. So another important message is actually the incidence of permanent DI is actually relatively rare following either microsurgical or endoscopic surgery. It takes more than 6 months to consider the patients as having permanent DI according to the latest literature. So it's actually giving us more longer time window for hoping the patient can recover from transient DI and become normal again. And also, during the surgery, manipulations of hypophysis of pituitary gland or stop or ears vascular supply is important to consider, and because this may cause the strain or damage the pituitary stop and may cause the symptoms of postoperative DI. So the limitations of our study is actually non-complete in our limited follow-up durations. Further study with the more accurate measurement of serum vasopressin levels and more longer follow-up, more than 6 months, may provide more comprehensive insight regarding postoperative DI. In this study, we only follow up the patients during the period of hospitalization with the maximum around 14 days. Well, maybe in the future, we have to add more longer observation periods so we can clearly identify which patients actually will become permanent DI in the future. And also, because this is surgical based, so the degree of manipulations has to be individualized, not only between operators, but also between patients, because intraoperative is very challenging. It cannot be generalized from one patient to the other patients. So in conclusions, the conclusions of our research is that tumor diameter and the type of tumor resections are potentially becoming predicting factors for transient DI occurrence following endoscopic surgery. And I do believe this actually can be meaningful not only for endoscopic, but also for a microsurgical approach. And these findings might increase our awareness about the potential complications during a preoperative and intraoperative management of patients with pituitary tumors. Thank you for your attention. If I have any questions, I would like try to answer.
Oh, sorry. Did I mute the microphone?
Yeah, I think so.
Yeah, thank you, Dr. Julius. So I would like to read a question from the floor. And question number 1 is from Dr. Ariandito Widinugroho. How did you dichotomize, determine the cutoff point for the tumor size, 2.8 centimeters? Did you use the median value, or was there any other consideration? And second question is, since hormonal disturbance was identified as a significant independent variable in relation with DI in your bivariate analysis, have you tried to explore this relationship in different hormones?
Thank you very much for the questions, Dr. Ariandito. For the first questions, actually, we dichotomize by a computerized manner. So before I dichotomize or determine this cutoff point of 2.8 centimeters, I compare the diameters, the largest diameter between patients without the DI and patient with DI. After I see that difference, then I perform a statistical analysis using AOC curve. So this statistical analysis is usually common to identify a cutoff point. So this cutoff point is determined among 92% and 80%, 90% sensitivity and 80% specificity. We're using 2.8 centimeters, so which is really high compared to if I decreasing the centimeter. So for the first questions, I use not my determinations, but it's computerized manner using a statistical methods. For the second questions, yeah, of course. For initial analysis, the finding of hormonal disturbance may influence or might predict that someone will have a postoperative DI. However, we do follow up these findings in a more reliable manner using multivariate analysis, and we found that hormonal disturbance is actually not so meaningful compared to tumor diameter and also a type of resection. Of course, in the future, maybe I have to examine more what type of hormonal disturbance maybe will influence. But of note, the incidence of hormonal disturbance in the macroadenoma patients is actually less common compared to the patient without hormonal disturbance. In our series, it's only 20%. The other 80% of the rest is actually having no hormonal symptoms. I hope that answered the questions.
Okay, thank you. Because of time, I would like to continue to other presenter. Our third speaker in this session is Dr. Muhammad Lukman Nul Hakim with the title of Comparison Burr-Hole Evacuation on Epidural Hemorrhage or Epidural Hemorrhage Patient between pre-COVID-19 pandemic and COVID-19 pandemic.
My presentation is using pre-recording video.
Thank you. Time is 15 minutes.
Who has attended this seminar. My name is Muhammad Lukman Hakim. I'm neurosurgery resident from Universitas Pajajaran and from Hasan Sadikin Hospital. I'm here to present my research with the topic comparison burr-hole evacuation on epidural hemorrhage patient between pre-COVID-19 pandemic and COVID-19 pandemic. I'm doing this research with Muhammad Zabro Alvin and Professor Ahmad. The first, why this is interesting for me to pick this topic, because head injury is one of the health and social problem in first country in the world. This problem is leading cause of death and disability in the world. Most of the cases of trauma occur in developing countries and low-income countries. Survey conducted showed that 90% of trauma occur in developing countries. And then this is the hot topic and become the world problem right now. The coronavirus about COVID-19 pandemic represent once in century challenge to human healthcare, with number of cases from WHO reported globally is now nearly 190 million, and the number of cumulative deaths exceed 4 million. If this trend continue, the cumulative number of cases reported globally could exceed 200 million in next 2 weeks. Now we have to know the impact of coronavirus in healthcare system globally. Affected globally in healthcare system, conducting surgery in the middle of pandemic era is challenging. How protocol were recommended and prepared from the emergency room. Screening for COVID-19 is mandatory for the patients, surgical team, and other assistants to minimize the effect of pandemic during surgery. Despite medical emergency, health and safety protocol in hospital setting must be implemented with many phases for health providers and patients and to evaluate the response time of surgery. There are reported two cases of delay emergency surgical procedure due to prolonged protocol and well-proven. And next, traumatic head injury has another problem. One of them is focal injury. And we know that's epidural hemorrhage is one of focal injury. Acute epidural hemorrhage is found approximately 20% of severe traumatic brain injury and account for 14 to 39 of craniotomy for hemorrhagic lesion. Mortality of acute epidural hemorrhage range from 9% to 33%. But when the lesion is evacuated before alteration of consciousness, the mortality rate may approach zero. Definitive treatment for epidural hemorrhage is craniotomy evacuation. The burhole evacuation is just one of the choice treatment for epidural hemorrhage. In the modern era, neurosurgeons seldom need the exploratory burhole. However, every neurosurgeon should be familiar with the procedure because CT might be unavailable in some cases during military campaign or disaster. Indonesia so many has disasters such as volcano, tornado, or earthquake, so many. So in the field, there are many ways to save the patient, and burhole is one of treatment of choice. Acute traumatic hematoma cannot be adequate addressed through burhole, because the definitive treatment is craniotomy evacuation, but the burhole is the process can be next for craniotomy evacuation because the burhole is one of the craniotomy. The method of my research is observation study. It was conducted at Hasan Sadikin General Hospital from January 2019 and December 2020. This research is descriptive observational. Data was collected from secondary data, namely medical reports. The result of the study are expected to determine the comparison of the patient with epidural hemorrhage who underwent burhole evacuation before underwent craniotomy evacuation at Hasan Sadikin General Hospital, Bandung. The sample taken were the patient with epidural hemorrhage who underwent burhole evacuation procedure before craniotomy evacuation with total sampling technique, and who met the criteria. Inclusion criteria is traumatic brain injury patient. The second, patient who has intracranial lesion such as epidural hematoma that meets the indication of surgery. Third, patient who underwent burhole procedure followed by craniotomy evacuation. And there are exclusion criteria for the sample is epidural patient who has another injury such as spontaneous intracranial and subdural hemorrhage. Patient with incomplete medical record data. Epidural hemorrhage patient in 2019 become sample of pre-COVID-19 pandemic, and epidural hemorrhage patient in 2020 represent a sample of COVID-19 pandemic. Here the result of our research. There are 122 patients who has epidural hemorrhage who underwent the craniotomy evacuation, whereas the pre-COVID-19 pandemic there are 67% with percentage 54.91%. In the COVID-19 pandemic, there are 55 patients with a percentage 45.09%. Here, the distribution of patient epidural hemorrhage who underwent burhole evacuation before craniotomy evacuation. In total, there are 7 patients, whereas the pre-COVID pandemic, there are 1 patient with percentage 14.28%, and COVID pandemic, there are 6 patients with percentage 85.72%. Here's the distribution of the patients who underwent Burkhold based on the grading. In mild head injury, there are 1 patient with percentage 40 and 28%. And moderate head injury, 3 patients with percentage 42 and 0.88%. In severe head injury, there are 3 patients with percentage 42, 86%. Same as moderate head injury, there are total in 7 patients. And the next, there are 7 patients. There, whereas they have deteriorating on the patient. Whereas the positive, there are 4 patients who have deteriorated with percentage 57%, and there are no deteriorating with 42 and 86%. And the patient epidural hemorrhage who has swirl sign on head CT scan, there are 6 patients with percentage 85% and 1 patient with percentage 14% total. So swirl signs show that almost all the patients have swirl sign in our epidural hemorrhage patient who underwent Burkhold before craniotomy. This is our reminder what is indication of management epidural hemorrhage in cervical management. In the volume of epidural hemorrhage must more than 30 milliliter regardless of GCS score, and there are midline shape more than 5 millimeters and thickness more than 15 millimeters and GCS score under 9. In contrast, CT scan show that this is indication of operation. But epidural hemorrhage can expand in 9% to 23% and 11% of cases respectively. And show that swirl sign may represent ongoing hemorrhage or presence of coagulopathy, and it warrants consideration for early surgical intervention. What is swirl sign is show that there are occasionally area of isoattenuated or hypoattenuated are seen within the hyperattenuating hematome on non-enhanced CT scan. There are suggestive of fresh unclotting blood. So this is show that there is ongoing bleeding in swirl sign. Here is what is swirl sign. Show that in non-contrast axial CT scan image show that red frontal epidural hemorrhage, which show the mixed density. They are hypoattenuated or hypodense in hyperdense. And in image B, there are corresponding angiogram demonstrate area of contrast extravasation in the region of hypodense suggestive ongoing hemorrhage. Here is in our situation. First, during the early month of the pandemic, our hospital was not equipped with on-site PCR equipment with COVID-19. And since the previous study had shown that COVID-19 has a typical pneumonia-like symptom without a specific clinical characteristic, it was difficult to diagnose. The only available kit for screening on that period was the rapid antibody test, which on previous reports showed promising sensitivity and specificity for SARS-CoV. Active infection. Although later study repeated those research, we used SD biosensor SARS-CoV antibodies kit for the rapid. When the patient came to our hospital, our patient who need to operate must be screened by binary team, because there are many patients who came with pneumonia-like symptom, and there are patients who infected of COVID-19 without any clinical symptom. They are without any symptom and can infect other people. In our hospital, binary team consists of team where are internal medicine, physician, pediatrician, intensivist, infection expert, and many others. The binary team policy for screening was at the point not catered for rapid decision type, especially for surgical patients. Due to technical problem, they need for more data to assess confirmation of those patients, whether are suspected or probable or COVID-19. Since the situation we encounter where a patient with acute deterioration and unable to operate quickly because of the system and pandemic COVID-19, Burkhold craniotomy or Burkhold evacuation remain relatively rapid and frequently effective treatment, who otherwise will likely die. So Burkhold, there is place of treatment of choice for this patient. We need to decide whether we must Burkhold evacuation first on epidural hemorrhage patient or go to craniotomy evacuation straight. The situation that we encountered, such a delay of operation, and there are deterioration of patient, and we look at the patient, there are CT scan with swell sign is determined for us to burhole first in order to save the patient. Conclusion, it was concluded there was a change in number of patients who underwent burhole evacuation in epidural hemorrhage patient during COVID-19 pandemic as 6 patients in 10% compared to 1 patient during pre-COVID-19 pandemic. The study showed the number of deteriorating of epidural hemorrhage who underwent burhole evacuation almost same, where are 4 patients who deteriorated and 3 patients who not deteriorated. But almost this patient had a suicide in their non-contrast head CT scan, whereas 6 patients, 85.72% had suicide, and 1 patient, 40% did not show a suicide. The limitation of the study, because there are new of the pandemic, there are change in healthcare system due to pandemic because screening system still adapting, and logistic is relatively limited. And in other area, maybe there are don't have screening system, and COVID outbreak still ongoing. There are many mutations of COVID-19 such as variant Kappa, Delta variant, and this is the limitation of our study. And then lack of sample due to short-term research, because my research conducted 1 year before COVID and 1 year last year for the pandemic COVID. And we know the COVID is still ongoing. For me, to suggest to do more research for this topic because it's important for us, because the delay must not obstacle for us to save the patient, because safety is the first for the patient. Thank you.
Yeah. Thank you for the presentation. It is 27 past 5. So thank you for reminding us that the COVID pandemic is influence our protocol for emergency surgeries. I would like to ask one question that it is logical that we have to wait the screening of COVID, either negative or positive, before doing emergency surgery. But is it in your hospital, do you have the protocol that even though positive patients with requiring emergency surgery still having the surgery?
Yes, thank you for the question. At the first, the protocol system still adapting. So we are still doing burhole evacuation at the first. But for now, there is change for the patient. We use equipment safety on level 4 for the suspected COVID-19. So the system is still changing and adapting. And the first patient still using rapid antibody. But now we are all the patient using PCR for all the patients who need the surgery. So change in 1 year and this year is still different.
So I hope there is no patients needed for a burhole anymore, I think, because of that.
Yes.
Okay, for we will continue our session. For the 4th speaker, I would like to call Dr. Hermawan Rahman with title of Correlation between Blood Alcohol Concentration with Severity and Prognosis of Traumatic Brain Injury Patients in Dr. Hasan Sadikin Hospital. Yeah, please, Dr. Hermawan, the screen is yours.
Yes, thank you for the opportunity. Moderator, please share my pre-recording video. Good to everyone. Please introduce. My name is Hermawan. I'm the 3rd year neurosurgery resident from Unpad Pajajaran University of Bandung. And then today I will be presented my paper about the correlation between blood alcohol concentration with severity and prognosis of traumatic brain injury in patient in our hospital in Hasan Sadikin Hospital. And then for the abstract, the traumatic brain injury is still the leading cause of the public health problem and also cause of the disability in many countries. And then this case is dominated by motor vehicle accident. And then within the 2018 until 2019 periods in emergency department of Hasan Sadikin Hospital Bandung, there are 2,108 cases and then 62.8% caused by motor vehicle accident. And then about 30.7% categorized in moderate and severe head injury with mortality rate up to 29.2%. And half of the case arrive in our department within 6 hours. 14% from this case were alcohol intoxicated and 37.8 cases were performed operation. And then the aims of this study is to measure the alcohol concentration in TBI patient that admitted to our hospital. And then we calculate the alcohol dehydrogenase serum using the ELISA method. And then we correlate the result with the severity, type of TBI lesion, prognosis, and the outcome. As a result, the alcohol dehydrogenase level less than 32.24 micrograms per milliliter has relative effect on the GCS on admission about 6.53 times with p-value 0.001, and then correlate with increasing risk to have multiple lesion 3.98 times higher with p-value 0.029, and then 5.27 times have a worse outcome with p-value 0.003. But the alcohol dehydrogenase level didn't correlate with length of stay of the patient. So for the introduction, according to the World Health Organization, predicted that TBI will become the third leading cause of death and disability in the world. The general incidence of TBI in developed countries is about 200 over 100,000 population annually. And then there is a strong correlation exists between the alcohol intoxication and the increasing risk for sustained all types of injury. And then the influence of the elevated blood alcohol level on the outcome of the severely injured patient still remain controversial. And so this study was proposed to see the correlation between the alcohol dehydrogenase serum and the characteristic of the TBI. For the methods of this study, we used, this is a cross-sectional study, and for the data collection, we performed the consecutive sampling in the 30 TBI patients with alcohol intoxication that admitted to our department. And then we measured the alcohol dehydrogenase serum using the ELISA method. And then we perform a statistical analysis. For the categorical variable, we compare by the visual exact test, and for the numerical variable, we compare by the t-test. And we also perform univariate and multivariate logistic regression analysis to determine the correlation about the alcohol dehydrogenase serum and the GCS on admission, type of lesion, outcome, and the length of stay of the patient. For the results, we have collected 2,108 patients, and then we have revealed that the alcohol dehydrogenase levels less than 32.24 micrograms per milliliter has relative effect on the GCS on admission, increasing risk to have multiple lesion, and correlate with the worst outcome. But this level of alcohol dehydrogenase didn't correlate with the length of stay of the patient. And then for the discussion, the independent factor significantly associated with alcohol consumption, including age, male gender, and mild and moderate TBI. And the GCS itself, it widespread use critical classification for TBI severity, also have prognostic value. The occurrence of associated injuries has been found to be associated with higher mortality and longer ICU, hospital and ICU stay in the patient with TBI. Attributing low GCS to alcohol intoxication in TBI patient may delay necessary diagnostic and therapeutic intervention. So for the conclusion from my study, young age, gender male, and mild and moderate TBI were independent factor significantly associated with alcohol consumption, and alcohol dehydrogenase level less than 32.24 micrograms per milliliters has relative effect on the GCS on admission and tend to increase risk to having multiple lesions and worsen but not correlate with the length of stay of the patient. But there is a limitation from my study. There is a still controversy remains, and further clinical basic research is necessary into pathophysiological mechanism to help explain the outcome that we have found. That's all my presentation, and thank you for your attention.
Thank you, Dr. Hermawan. There is a question from the chat. Is there any difficulty in sampling collection regarding BPJS policy about diagnosis of alcohol intoxication?
Yes, thank you, moderator, for the question. Actually, in performing this research, yes, there is a problem with the patient policy due to the if we diagnose the patient with alcohol intoxication, the patient will be denied to use their government insurance or their BPJS in our hospital. So we clearly make sure that the subject's privacy, so the patient still can use the government insurance in our hospital instead of being part of our sample in our research. Thank you.
So the research is not privately funded or using the BPJS system or something?
This research is privately funded by us, but we collect the sample from the patient which admitted to emergency room. So many patients admitted to us come to use their BPJS to hospitalize. So we must clearly save the patient privacy, so they still can use their BPJS instead of we diagnose the patient with alcohol intoxication.
Okay, thank you. And one question: was the sample collection is taken from all the population or sampling method?
We perform the consecutive sampling for this research. So we set up the time period. So all the patients that admitted to our hospital with TBI and suspected alcohol intoxication, we collected into our patient sample.
Okay, thank you.
Thank you.
Any other questions? If there is no other questions, then we will continue our next speaker. Our next speaker is Dr. Dili Marayuzan Akbar Pratama with the title of Rise of Traumatic Brain Injury Admission During Large-Scale Social Restriction Due to COVID-19 Pandemic. Dr. Dili, are you ready to present your presentation?
Thank you. I already sent my pre-recorded video.
Okay.
Can play the video, please?
Good evening, Professor, doctors, and all participants. First of all, I would like to introduce myself. My name is Dili Marayuzan Akbar Pratama. I'm a resident of Neurosurgical in Universitas Pajajaran in Bandung. And thank you for the opportunity for me to present my research with my supervisor, Dr. M. Zafrullah Arifin, a neurosurgeon, as my mentor. And let me first read my title of research: The Rise of Traumatic Brain Injury Admission During Large-Scale Social Restriction Due to COVID-19 Pandemic. So here is the abstract. As you know, the WHO stated that COVID-19 as global pandemic in March 2020. And in Indonesia, the government urged public to follow rules in large-scale social restriction to prevent transmission COVID-19 locally. Despite of social restriction and pandemic, people were still admitted to hospital due to traumatic brain injury. So the aim of our study is to compare the emergency admission of traumatic brain injury cases to our teaching hospital during large social scale restriction before COVID-19 pandemic. And the method is, this study was a single center observational retrospective study, which was conducted in our teaching hospital, Dr. Hasan Sadikin General Hospital, Bandung. And all data were collected from our emergency admission registry from April 22nd until May 29th, 2020, as the large-scale social restriction was being implemented totally in Bandung. Data on demographic characteristic severity of traumatic brain injury, Glasgow coma scale, presence of any kind of skull fracture, intracranial hemorrhage, and any emergency trauma neurosurgery performed were analyzed. As a result, the emergency admission due to traumatic brain injury during large-scale social restriction was 47% higher than total admission in previous year during the same period of time. And there was no significant difference in age and sex distribution, skull fracture, intracranial hemorrhage, and number of emergency neurosurgery performed between 2019 and 2020. However, there was a significant differences between Glasgow coma scale and classification of head injury during large-scale social restriction with p-value less than 0.05. So the conclusion is, we reported the increasing of traumatic brain injury admission during large-scale social restriction, and the referral system and accessibility to medical help may attribute to this phenomenon. So this is the first discovered and spread across the world from Wuhan, from China in December 2019. And SARS-CoV-2 or COVID-19 pandemic has caused severe morbidity and mortality, and until WHO stated that COVID-19 as a global pandemic in March 2020, and since then a lot of health and social policy has been implemented throughout the world. In Indonesia, government urged public to follow rules in large social restriction. So including the people have to staying at home, and there is domestic and international travel ban, limitation of public gatherings, main roads and social places are closing, and then all of people have to work from home and home-based learning for the student. And also across several large cities, large social scale restrictions are implemented to prevent the transmission of COVID-19 locally. In Bandung, the total large-scale social restrictions were conducted from April 22 until May 27 in 2020. And during this period of time, large number of main roads, mall and shopping centers, school, public service places, education and governmental buildings, and also religious centers were closed. And also the other outdoor activities were prohibited. Only vital reasons such as medical issue or hospital and grocery shopping which were impossible to do from home alone. Traumatic brain injury has been one of the leading causes of morbidity and mortality in Southeast Asia. Despite of social restriction and pandemic, people were still admitted to hospital due to traumatic brain injury. The aim of our study is to compare the
emergency admission of traumatic brain injury cases to our teaching hospital during large-scale social restriction and without it before COVID-19 pandemic. So the study was a single-center observational retrospective study which was conducted in our teaching hospital, Dr. Hasan Sadiqian Hospital in West Java, Indonesia. All data were collected from our emergency admission registry from April 2022 until May 27, 2020, as the large-scale social restriction was being implemented totally in Bandung. And during the same period of time in 2019, all patients with traumatic brain injury were included. Data on demographic characteristic, classification of head injury, and then we can see in this table mild, moderate, and severe, and then Glasgow Coma Scale score, presence of any kind of skull fracture, intracranial hemorrhage, findings, and any emergency trauma, neurosurgery performed were collected. And continuous variable presented in median and value nominal data were shown in frequency. So there is the differences between variable were evaluated with chi-square and Fisher exact test, and also Mann-Whitney U test. So this is the result of this study. The result was presented in this table that total emergency admission due to traumatic brain injury during large-scale social restriction for around 5 weeks were 55, and which show 47 higher than total admission in previous year during the same period of time in 2019. And there were no significant differences in age and sex distribution, and also sign of skull fracture in skull X-ray, intracranial hemorrhage in head CT scan, and number of emergency surgery performed between 2019 and 2020. However, there was significant difference between GCS score, there is, and classification of head injury, which contain mild, moderate, and severe. It appeared to be higher, and severe head injury tended to decrease. So, with the result of this study, this is the discussion. So, from our study, the traumatic brain injury admission increased during large-scale social restriction due to COVID-19 pandemic compared to the same period of time during the previous year. Several studies from countries across the world which implemented a strict rule of social restriction, a total lockdown towns and cities shown opposite result. In a single center study in Sydney, in Australia, a significant drop of TBI admission was observed during lockdown from March 1st until April 30, 2020, compared to the registry of TBI with the 5 preceding years, the same period of time. And also the same pattern on study in Netherlands, in which there was 36% drop of emergency attendance for traumatic brain injury during period of lockdown in March 18 to April 6, 2020, compared to 2019. And there is also a similar pattern in study from another European country and also United States, and also in India reported another similar results. So this result were expected due to severe social restriction and lockdown, which further kept road traffic accident and falls low. Our study showed that there was a rise of mild and moderate head injury admission. Conversely, was decline in severe head injury. And the result was conflicting with the similar study in India. So the reason not was reluctance in seeking medical help for mild and moderate injury due to fear of COVID-19 exposure. This could be caused underreporting most traumatic brain injury cases for mild or moderate head injury. The apparent rise of severe injury in other several countries show the similar result. And our study showed that traumatic brain injury attendance to our teaching hospital emergency. In our study show that traumatic brain injury attendance to our teaching hospital emergency department rose during the large-scale social restriction. Various reasons could contribute to this phenomenon. The first one was that our hospital is the highest provincial referral hospital in the area with fully functioning emergency room for trauma during the pandemic, where other local hospitals maybe decrease their capacity and human resources during early pandemic in last year, owing to limited resources of testing kit of COVID-19 and also isolation of large number of healthcare workers exposed to COVID-19. Therefore, patients tended to seek medical help from health facility with full assurance of medical support of trauma. The closing of a large number of roads may also contribute to the pattern of this emergency room attendance. Patients may seek medical help to our hospital, which were located in the city center with numerous access uninterrupted with the road closing. It's maybe different with another hospital. However, the further study with more complete data should be pursued in order to investigate this traumatic brain injury pattern. And this is the limitation of our study. The lack of data is one of the biggest limitations of the study. We only retrieve data from only one center in our teaching hospital, Dr. Hasan Sadikin Hospital, and narrow range of variables presented which limited the factual phenomenon throughout traumatic brain injury admission pattern during the large social scale restriction across the city. Moreover, the etiology of traumatic brain injury was not reported due to lack of information in registry of the emergency room neurosurgery database. So this could be useful to show how social restriction could change the pattern of traumatic brain injury causes during the pandemic. Additionally, we were unable to confirm the reason for unknown data, whether the reasons were the reluctance of patients or family to refuse further investigation against medical advice or other medical preferences due to the unfavorable prognosis. As a conclusion, traumatic brain injury attendance during large-scale social restriction due to COVID-19 pandemic showed 47% higher than total admission than the previous year during the same period of time. The reason for this pattern was possibly related to the referral system, medical help seeking behavior, and pattern of road closing. So, thank you for the attendance of professor, doctors, and all participants. This is my research. Thank you.
Thank you, Dr. Dili, for the presentation about the social restriction. There is a question from Dr. Justinus Robi from UNPAD to Dr. Dili. Based on your study, do you think lockdown is effective against number of TBI patients, or how about the TBI patient come to your center? Are they came with COVID infections?
Thank you, Dr. Justinus Robi, for the questions. Based on my study, the result was there is a rise in traumatic brain injury during the lockdown, maybe because it's still not effective for all the people stay at home, but maybe we can also doing another research in this period for seeking the number of the new traumatic brain injury in this pandemic. So maybe now I cannot say because there is no evidence for these questions, but in my opinion, the lockdown or the social restriction maybe help us to prevent the traumatic brain injury because a lot of people still stay at home, which means the road is maybe more safe. And in
Semuanya
our,
dia hari ini.
in our center, some of the traumatic brain injury patients came with COVID-19 infection because in our center, almost all patients were routinely checked for the COVID-19 infection. Maybe it can swab for the antigen, or maybe some of the patient will do the PCR from the PCM. So all patients in our center were screened for the COVID-19 infection.
Thank you. If I may, I would like to give a comment about this. We cannot take any conclusions from a data that taken from single center, because in Bandung, Hasan Sadikin is the tertiary health center. So we have to we have to consider either the primary health center or secondary health center is available or not, because if they were not available, then every cases will go to Hasan Sadikin, and TBI cases was increasing. I think we have to take a consideration of the cases that maybe regional cases should be taken for a statistical analysis, I think. Okay, any other questions? So we would like to continue to our last speaker is Dr. Michael, with the title of Association between the Severity of Head Injury and Basal Skull Fracture.
Okay,
also, Dr. Michael is from Hasan Sadikin also. Thank you.
Okay, thank you, Dr. Tommy. I have sent my pre-recorded video to the committee, so please proceed with my pre-recorded video. Thank you.
Okay.
Good afternoon to all the participants and conference committee. My name is Michael, and I'm second year's resident in the Department of Neurosurgery, Faculty of Medicines, Pajajaran University, Hasan Sadikin General Hospital, Bandung, Indonesia. Thank you for the opportunity that has been given from Dr. Muhammad Zafrullah Arifin and the committee so that I can present my abstract entitled Association between the Severity of Head Injury and Basal Skull Fracture. Head injury are the leading cause of disability and death in the productive age population. The incidence of head injury in developing countries is increasing as the number of motor vehicle users grows. The aim of the study is to measure the association between the severity of head injury with basal skull fracture. Head injury are the cause of death from the most severe trauma after arriving at the hospital. World Health Organization data from 2015 shows us that the traffic accident account for 1.25 million cases in 2013. Also, Riskesdas, or Riset Kesehatan Dasar, conducted in 2013 states that there is an increase in head injury prevalence to 40.6% compared to data from 2007. High energy impact is considered to be the underlying pathomechanism between head injury and basal skull fracture. And basal skull fracture is commonly associated with intracranial pathology, and this type of fracture could be occult and unspecified, therefore leads to complications such as infection. We conduct a study with cross-sectional design, then we collect data retrospectively from medical record with consecutive sampling technique of 1,058 head-injured patients from January 2017 until December 2019 that admitted to Department of Neurosurgery, Neurotrauma Division in Hasan Sadikin General Hospital. From medical record, we classify independent variable to mild, moderate, and severe head injury, and dependent variable to with and without basal skull fracture. Finally, we conduct chi-square statistical analysis to evaluate the association in between. After we conduct the method thoroughly, then we get some result as shown in this slide. This is the table of head injury characteristic distribution. The most frequent age interval distribution from this study is 15 to 29 years old, and the least frequent is more than 60 years old. From the severity of head injury, we get mild head injury is the most prevalent grading severity. From basal skull fracture, actually we get no basal skull fracture as the most prevalent, then anterior and middle basal skull fracture. And male patient is more frequent than woman patient in all age group. From all 1,058 patients, we conduct chi-square analysis to provide whether the null hypothesis could be rejected or not. This is the observed table that we got from collecting all the samples. From the observed table, then we can proceed to make the expected table with formula of total horizontal times total in vertical divided by 1,058 as this total study population. In this expected table, there is no value below than 5. And total population from this table is 1,058. So we can conduct chi-square analysis as its requirements meet. After we have the observed and expected table, then we can proceed to count this test statistically using the formula of quadrant result of subtraction from observed and expected value divided by expected value. Then we sum all the result and we got 61.557 as this test result. This study has 3 independent variables and 2 dependent variables, so the degree of freedom is 2. Then we calculate the critical value of this test with alpha of 0.05. Here we got the value of 5.991. From all 1,058 head injured patient data, we conduct chi-square analysis as shown in previous slide. Then, as this test statistic has value of 61.557, that is greater than critical value of 5.991, hence the null hypothesis which stated that no differences between the severity of head injury and basal skull fracture could be rejected. Factors that associated with basal skull fracture are age interval as external fracture and severity of head injury. Head injury with basal skull fracture most commonly occur in patients with age interval 15 to 29 years old. Cerebral contusion is the most common type of intracranial lesion associated with basal skull fracture. The conclusion, the severity of head injury has association with possible basal skull fracture an intracranial injury that can urge us that the patient may have more unfavorable outcome. So this is briefly about my presentation. Thank you for your attention.
Thank you, Dr. Michael. We have 10 minutes before closing. Are there any questions from the floor or audience?
Dr. Chomi, there's a question, I think.
Oh, okay. There is a question from Neurosurgery Bandung to Dr. Michael. I have one question. What is the limitation of your study? Thank you.
Okay. The limitation of my study, the first is the study was conducted in urban area, as have stated before that the study was conducted in Hasan Sadikin General Hospital. So that the study is unable to represent the condition elsewhere in Indonesia. And the second one, we conduct a study with cross-sectional design. Then we collect data respectively from medical records. So we got limited clinical information. And the last, the patient outcome were not assessed with Glasgow Coma Scale. That's all, Dr. Tommy. Thank you.
Okay, thank you. There is another question from Dr. Ariandito. Dr. Michael, specifically which level of severity in TBI that was significantly related to basal skull fracture? And have you performed any multivariable adjusted logistic regression in this case?
Okay, thank you, Dr. Ariandito. The first question, yes, there's a significant that moderate head injury is the most moderate head injury is the most prevalence from my study, and I don't perform any multivariable adjusted logistic regression in this case. Thank you.
Okay, so Dr. Michael only did an analysis of the severity of brain injury and with basal skull fracture. I have a question. Why only basal skull fracture? I mean, you did open the files of patients to do retrospective study, but why only skull-based fracture? Why not? I mean, why didn't you take any like contusion, yes or no, and like penetrating injury, yes or no, and the outcome also can be evaluated by that. Do you have any consideration about that?
Because I conduct this study because my supervisor I did this study, so I don't have another factor that I have to learn about this question and this.
Okay. Okay, thank you. Are there any more questions? We have 6 minutes. Or from the first questions for other speakers in this session is okay. Are there any more questions? Okay, so if there are no more questions, then I will conclude this session. And thank you very much for all the participation of speakers and participants. I would like to return the screen to the committee. Thank you.
Thank you, Dr. Tommy. Thank you for leading this session. We thank the audience for your attention. Thank you for all the speakers. This is the end of the Young Neurosurgery session, and we would like to invite you to the last session of our Congress, the inaugural session. You can find the link to the session in the chat box below. Good evening, and thank you.
Okay, thank you.